Hello everyone, and welcome to our presentation. We will be presenting a complex case I worked on as a patient advocate. The client suffered a new traumatic brain injury. First, I'd like to introduce myself. I'm Melissa Cardine, and I will be one of the co-presenters while you listen to this presentation. My business partner and colleague, Jennifer Whalen, will also be a presenter on this presentation. We have been working together since 2018 teaching advocacy. We are both very excited for you to hear this presentation.
Hello everyone. We have some ambitious objectives for this presentation. First, we will review the patient advocacy process and explore the effect it has on the entire family. Investigate the intersection between complex neurological care and the healthcare system. Recognize the effect insurance coverage has on client health and experience. We'll discover clues that might signal future litigation or attorney involvement in an advocacy case. We'll explore methods for evaluating a case after the advocacy process is complete, and apply some Patient Advocate Certification Board ethical guidelines to the advocacy process. Let's start with some of the background information of this case. So this is one of Melissa's cases with the Bridge RN Patient Advocates, her private advocacy business. She was contacted several years ago by the father-in-law of the patient to request advocacy services for his son-in-law, Steve. So Steve is a 45-year-old man who was hit by a car while walking home from a work function and suffered a severe traumatic brain injury. He worked for a large corporation with a self-funded insurance plan. Steve is the primary financial provider for his family. He lives with his wife and 2 young children, and his parents also live nearby. His father-in-law, who has healthcare administration and health insurance work experience, and his mother-in-law also live nearby. He has a large group of supportive friends and family in town. Now let's look at some information about traumatic brain injury. A traumatic brain injury is defined as an alteration in brain function or other evidence of pathology caused by an external force. Now that's a pretty broad definition. It can include anything from a mild concussion to severe disability or even death. According to the Agency for Healthcare Research and Quality, this is mostly classified by state of consciousness after the incident, timing of lost consciousness, imaging, memory loss, and Glasgow Coma Scale. Steve's TBI was considered severe, with the loss of consciousness requiring intubation and ventilation for 2 weeks. The CDC lists statistics regarding 5-year outcomes for adults who received inpatient rehabilitation after a moderate to severe TBI. 22% of those died, 30% became worse, 22% stayed the same, and 26% improved in health status. But we know that this does not predict the story of Steve's recovery. Steve and his family experienced something quite different. Melissa describes his family's experience by saying, "It was a roller coaster and one hurdle after another." The first hurdle was, is Steve even going to survive? Once the family knew he was not going to die, they went full force to try and do everything possible to aid his recovery. No one knew what would happen to Steve and how much function he would ever regain. The family questioned every medical provider, asking for clues as to what the future would look like for Steve. Steve overcame hurdle after hurdle, surviving, coming off the ventilator, along with being able to swallow and eat. But the family was in a place of limbo. Every day, they didn't know what to expect or not to expect. What was ahead at the next turn? They didn't know what the future held and if he would ever be the same. Let's briefly look at some key points on rehabilitation. As we all know, early rehabilitation is the key. The goal of rehab should be to return to previous function. It should also be individualized and highly focused on the type of rehab they need. You'll hear people talk about neuroplasticity as well. It is, quote, the brain's ability to modify, change, and adapt both structure and function throughout life and in response to experience, by Voss et al. This is the reason rehab is so important for our clients, because the brain does have the ability to remodel and help patients regain function. The timing of rehabilitation and therapy is important because most improvement in function is seen within 6 months, although it may happen years later. You will hear lots of different qualifiers of the words rehab and therapy: inpatient, outpatient, holistic, neuropsych, speech, occupational, physical, multidisciplinary, community, integrated, and more. Some of these terms have actual meaning in regards to reimbursement, quality of care, and type of care. Others have meanings that vary depending on the facility offering them. It's important that we don't assume we know what they mean, but ask and dig a little bit deeper for our clients. One person's integrated can look a lot different from another person's integrated rehabilitation. So Melissa and I have spoken about what she's learned about how improvements can be assessed for her clients with therapy. So she was telling me a story about how she attended a follow-up appointment with Steve and his wife with a nurse practitioner who worked for the physiatrist. So the nurse practitioner almost immediately made a comment how much improved Steve was since the last time he saw him. So the wife was really taken aback by this statement, yet at the same time, she was happy to hear that the nurse practitioner noticed how much Steve was improving. The nurse practitioner then explained to us how the providers notice the most improvements in patients since they only see them every month or maybe every few months. Then it's usually the therapists who notice the most improvements. They usually see the patients maybe 2 to 3 times a week. It's the family who works with their loved ones every day, all day, who have a difficult time seeing any improvements. And he then pointed out to us the patient's perspective. They're the ones that have the hardest time noticing any improvements in their functioning. So just think about that when working with clients. Think of their perspective. From that moment forward, it definitely helped the wife and Melissa really empathize with how Steve must be feeling through all of this. Here's an overview of the transitions of care that Steve has gone through. In a span of 18 months, he went through 6 different settings, some medical and some residential. We will get into the details of 3 of these settings: the skilled nursing facility, acute inpatient rehabilitation, and home, during the rest of the presentation. First, let's remind ourselves the definition of transition of care. It's really any shift in healthcare settings a patient experiences as their condition and care needs change, that often involve a change in providers, caregivers, medical record systems, monitoring methods, and medication administration. The World Health Organization lists several adverse outcomes that patients may experience during transitions of care. As advocates, we know that these poor outcomes are possible, and much of our job is to work to guard our clients from experiencing these outcomes. So let's look at Steve's transitions. He was admitted to a trauma intensive care unit at a large local hospital for 2.5 weeks while he was on a ventilator. From there, he went to a specialty hospital where the goal was to wean off the ventilator, and he was there for about 2 weeks, and he was able to get off the ventilator. After that, he was transferred to a skilled nursing facility. So Melissa was not hired until Steve had been at the skilled nursing facility for several weeks. After that, he spent 6 weeks at the acute inpatient rehabilitation facility, then home, and then finally to a group home. Now, Melissa, what did Steve's family tell you it was like going through some of these early transitions before they hired you?
I reached out to the wife as Jennifer and I were preparing this presentation. She was explaining what it felt like when she had to make decisions of where Steve was going from the trauma ICU on a ventilator to a specialty hospital where they would take care of him on the vent and also try to wean him off the vent. The wife pointed out how the representative for the specialty care hospital hung out with them in the lobby, eating their food, and it felt very used car salesman-like. I asked her to expand. It felt like she was trying to sell them on having Steve go to their specialty care hospital. We then discussed how one of the next big decisions she needed to make was where Steve was going after the specialty hospital. She was provided a list of skilled nursing facilities from the specialty care hospital. I'm sure some of you experienced this list. The hospital gives the family a list of places, and it is up to the family to provide their top choices. The wife was not provided any direction on how to choose a facility. She did what she thought she was supposed to do. She went and visited the places, yet really didn't know what to ask or what to look for when choosing a skilled nursing facility. She chose the facility based on what it looked like. It was recently remodeled and looked very state-of-the-art. That's sad that she had that experience when she is trying to decide on the best possible care for her husband. I think it is part of an advocate's job to remember that healthcare is a business, and our clients don't always know that. Oftentimes, patients are treated as commodities, something that has economic value, and we have to work to make sure that our clients don't feel that way. So I was asking what she thought was the advocate's role when helping a family choose a healthcare facility, such as a post-acute specialty hospital or SNF, as in this case. First, we should allow the family space to choose by keeping separation between facility representative and family, if possible. Research the facility for the family. We can ask questions like, who owns it and what is the company's history? Who is the current management? How long have they been there? We could ask about therapy. How many patients have they worked with? In this case, with traumatic brain injuries. What were their outcomes? Who oversees the care? What is their experience with patients, in particular with traumatic brain injuries? How often do care planning meetings occur, and who attends? Are you allowed to attend? What are staffing ratios for caregivers? What level of care are they competent with? Remember, these are just some of the questions, and we will talk more through about the skilled nursing facility Steve went to.
So while Steve was at the skilled nursing facility, his father-in-law contacted Melissa with concerns about discharge to home discussions the facility had already initiated, the fact that therapy had been stopped, and just a general feeling of uneasiness about the situation. So I had an opportunity to speak with the father-in-law recently and recorded some of the audio with his permission, of course, and I'd like to share that with you.
Can you share a little bit about your professional background and why you felt the need for a patient advocate in this situation?
I'm very happy to do that and honored to be asked.
Thank you.
I have over 40 plus years in the healthcare industry and continue, even though I'm semi-retired, continue to do some consulting, coaching, and training, primarily in the healthcare space. The majority of my career was in healthcare administration, both on the provider and the payer sides. And so because of that, there was one thing that I saw a need for and felt like I could do, and that was to help organize and manage the process for my son-in-law and his wife, my daughter, and the entire family, both sides, which were both near my son-in-law, where he and my daughter and their family live. So I felt very comfortable in and around healthcare and felt like I could add to and add some value in terms of organizing and managing the process. The second thing I felt like comfortable doing was advocating for the patient and my son-in-law and the family. And as we all know and have experienced, many people enter the healthcare need for healthcare services feeling like they're at the mercy of the system, the professionals who know everything. Well, they don't. And so over the course of 40 years plus, I've become not hesitant to ask a question or intervene when necessary, both with the clinical and the administrative process, but certainly more confident on the administrative process. And to do it in a professional way, but to really make sure that my son-in-law and the family are getting what they need.
And the second question that I asked him was, can you tell us what you thought you needed from a patient advocate and what you thought Melissa could do for you?
Yes, I was very, very clear and very happy to say that Melissa exceeded my expectations on these, but I was very clear what I needed. Mm-hmm. I knew this would be bigger than what I could do by myself. I needed a partner to work with me. Mm-hmm. It was very important. I mean, I'm also trying to be father to my daughter, father-in-law to my son-in-law, but also trying to take on this role of helping organize and manage the process. And I knew it would be advantageous to have someone at my side, someone I could call on, to truly be a partner with me throughout the entire process of my son-in-law's journey through care and recovery. My clinical training is originally in counseling psychology. Mm-hmm. My administrative experience covers all of healthcare, med-surg, psychiatry, inpatient, outpatient, and as I already mentioned, both on the provider and the payer perspective. I really needed the one major expertise that I recognized and knew that I needed was on the medical clinical side. And that bore itself out in the very first case management meeting we had when I had questions about medications, to have Melissa sitting beside me at the table. I asked the questions, but then Melissa added her expertise and knowledge from her clinical training that made my questions not just empty questions from the father-in-law. Mm. And that was invaluable. Mm-hmm. So working as a partner from a true advocacy, especially on the clinical side, and especially acting as a partner to me and the whole rest of the family was incredibly important and what I needed from a patient advocate.
Yeah. Well, thank you so much. Really appreciate you sharing your perspective on this.
Thank you.
So I just thought that it was, really interesting to hear that this was a person who had this high-level healthcare administration and insurance experience and who still reached out and needed an advocate and saw the value of advocacy services. I want to set the stage for what was occurring at the skilled nursing facility. Now, Steve has spent over 2 weeks in the trauma ICU, 2 weeks at a specialty care hospital getting weaned off a ventilator, and then was discharged to the SNF. The family did not know, but the SNF had recently been bought by a new company. It was under new management and had recently undergone a renovation. On the first day, Steve was found on the floor in his feces. The family had to print and give to the facility the CMS care regulations in order to receive appropriate care for Steve. Now, Steve had been going to therapy 1.5 hours a day with notes from his therapist that he was improving, he was progressing. Then suddenly the family was told that he would not be receiving any more therapy, no explanation. He had also not received any neuro evaluation during his stay there and no swallow evaluation, and he was still receiving nutrition through a gastric tube. So also prior to Melissa's involvement, Steve's family was told abruptly that he would be discharging to home. Sounds like a great situation, right?
We set up our initial meeting to take place at the wife's parents' home. The wife, her parents, and Steve's parents were all there. We sat around the dining room table. I asked them to start from the beginning when the accident occurred. I took notes, which helped us start creating a medical timeline. Almost an hour into our meeting, the skilled nursing facility called. The wife answered and was told by the case manager that Steve was no longer receiving therapy since the insurance denied his care. I still vividly remember the look on my client's face, her trying to control her anger, disbelief, not knowing what to say. At the time of this call, Steve was dependent on a feeding tube. He was being transferred using a Hoyer lift, and he could barely sit up in a chair without a brace. It was unfathomable that he was coming home. With prompting from us, the wife told the case manager we were on our way over there and that we would like to have a care planning meeting. When we arrived at the SNF, we were guided to a conference room. The only person who showed up to the meeting was the social worker. We explained that we knew and asked for the director of therapy, the nursing director, and case management to also be present at this meeting. I was shocked to learn this was the first care planning meeting the family had with the staff at the skilled nursing facility. As a team, we created a list of tasks for each one of us at the meeting. We all agreed that our focus needed to make sure Steve was receiving the care he needed. After discussion, therapy stated they would not be stopping therapy and would resume immediately. The case manager agreed to follow up on the denial of his care at the SNF. Another item that needed to be addressed prior to discharge was getting a swallow evaluation done in order to advance to his diet. We also started discussing what the best level of care for Steve was. Fortunately, I just completed working on a neurological case where a client had 2 brain aneurysms and followed her from the acute care setting to acute inpatient rehab and home with 24-hour care. So I was familiar with assisting one in navigating the neuroacute rehab arena. Steve was being cared for by a nurse practitioner under the care of a physician who was not a champion for Steve. The case manager told us the physician did not think Steve still needed to be there. Our concerns were the provider's lack of experience caring for patients with traumatic brain injuries and the provider not advocating for Steve. We discussed the potential for more therapy for Steve. This would entail him being evaluated by a physical medicine and rehabilitation physician to see if he was a candidate for acute inpatient rehabilitation. We also explored all options for next level of care, including private pay neuro rehabs, private pay care homes for those with traumatic brain injuries, and going home with 24-hour caregiving. It sounds like there was a lot of work to do, and there really was, with many different balls in the air all at once. The role of the advocate was to help coordinate the care for Steve by doing as much work as possible, also by delegating to family members. So looking at the task at hand, one of the first items I assisted with was the follow-through with getting the swallow evaluation done. Therapy at the SNF was saying they ordered it, yet they were awaiting authorization. I called a previous speech therapist I worked with with another client who worked at a SNF to ask how she gets swallow evaluations done at their facility. She gave me the name and number of the company. I called the company, and it just so happened they had the order for Steve's swallow evaluation and informed me authorization was not needed. I informed them of the urgency to have this completed, and they were able to come to the SNF in the next 2 days to get the swallow evaluation complete. The next area that needed to be addressed was we were being told Steve's insurance would no longer cover his care at the SNF. We asked the case manager to appeal the denial and ask for a peer-to-peer. The provider at the SNF would not do a peer-to-peer. Remember, this was one of our concerns, that the provider who oversees Steve's care either was not competent to be managing his care or he really didn't care. Our focus really turned into getting Steve into acute neuro rehab. The father-in-law, who you heard from previously, was well connected. He was able to get Steve in for an evaluation at a major neurological institute in Phoenix. Steve was determined appropriate for acute rehab. Next steps were getting insurance to approve. We were getting the runaround from the SNF regarding insurance, so the wife and I called the insurance company ourselves. This is where it gets very interesting. We were told by the insurance that no claim has never been submitted by the SNF. Therefore, there was no denial. So let me say that again. The SNF never submitted any claims to the insurance. Therefore, there was not a denial. At this point, we knew the executive director by first name. We sat down with him and explained what we just learned. He told us more or less not to worry about the insurance and asked what he could do to help. We asked them to submit a claim and provide medical and therapy notes to justify acute rehab. We compiled 107 pages of medical and therapy notes. We wrote out Steve's story, the family experience and frustration, and what the goals were for Steve. We ended up leaving the SNF without knowing if insurance was or was not covering the care he received there. Steve is transferred to the inpatient neurological rehabilitation facility. We know that rehabilitation given in a multidisciplinary neurorehabilitation facility has been found to be more effective than rehabilitation in a non-specialized facility because of the effectiveness of cognitive evaluation and training. First of all, within days of going to acute neuro rehab, we all knew that this is where Steve needed to be. He was being seen daily by the physiatrist. He was receiving 3+ hours of physical, occupational, and speech therapy a day, and a neurologist was managing his seizures and medications. The wife and family were very involved in his care at the facility. It just felt right. We were actually able to take a deep breath. Steve was admitted under private pay with the commitment and understanding that the facility would submit a claim. Here's where the confusion happened. The acute rehab submitted a claim and it was denied. This is not what we wanted, yet this denial allowed us to do an appeal. Prior, we were not able to do an appeal because there was nothing to appeal. There was a lot of confusion. When we spoke with the insurance company, on their end, there were no claims submitted after the specialty hospital until this claim for the acute rehab. So it looked like Steve went from the specialty hospital to no care at all, and now we are asking for acute rehab. Inconsistencies in communication between the SNF and insurance company started the confusion about where he is and why he needs this level of care. A peer-to-peer was also done. This peer-to-peer came into play because of an authorization request, not a denial of services already rendered. So the SNF never submitted any claims. Then the acute inpatient rehab submits an authorization for services. This was denied. Then a peer-to-peer was done and the insurance provider wrote us his final external review decision. This is what that decision said. This patient continues to have functional deficits due to a traumatic brain injury that occurred on 2/22. He remains dependent in activities of daily living and has ongoing fatigue and cognitive impairments. He has not made any significant objective functional gains since admission to a skilled nursing facility on 3/23. He would not be expected to be able to participate and tolerate 3 hours of daily rehab services due to his fatigue and ongoing cognitive deficits. And the 3 hours of daily therapy is a requisite criteria for acute inpatient rehab admission based on Medicare and Interqual. His recovery instead is expected to be slow and protracted based on the severity of his brain injury, and thus he can continue his rehab in a lower level of care setting. Therefore, the request for inpatient rehabilitation admission is not medically necessary. Note, we received this letter on June 14th, and Steve had been inpatient at neuro rehab since May 25th.
Let's look at the multidisciplinary team that was caring for Steve. First, there's the physiatrist who manages all of the therapy and works in the area of physical medicine and rehabilitation. Then there was the team of speech, occupational, and physical therapists who are directed by the physiatrist. The neurologist will manage all of the medical issues that go along with a traumatic brain injury. Steve developed seizures while at the neuro rehabilitation facility. Unfortunately, seizure medications may dull neural pathways, may inhibit brain healing, making it harder to see progress from therapies. A neurologist can adjust those medications to see the level of cognitive and functional performance while keeping Steve safe to make sure that he's having as few seizures as possible. It really is a tricky balance, and that's why you want to have a neurologist on board. Neuropsychiatrists and neuropsychologists can also be used to do kind of in-depth evaluations, testing, to look at cognitive performances and find any deficits that may not be seen, some things that the therapists need to work on. So make sure that you check with either the neuropsychiatrist or psychologist to see what specifically they do for their testing, what types of recommendations they can make for your client. Oftentimes your clients will seek alternative treatments in addition to the care that they are receiving from traditional medicine. So in this case, Steve's wife brought him to a neurofunctional chiropractor for treatment. And just in those cases, it's really the advocate's job to make sure that all the providers are aware of who the patient is going to see for providers, making sure that they're all on the same page with what type of treatment and care your client is receiving. And that's really what the advocate's role is communication, collaboration within that complete medical team.
Steve was receiving outstanding care at the neuro rehab, but insurance reimbursement continued to plague the family. As previously stated, the insurance denied his care. The family and I met several times to create an expedited external independent review for authorization for acute inpatient rehabilitation. We felt that the insurance company did not have a good understanding of everything that took place up until this moment due to the lack of claims by the SNF. So we wrote out a comprehensive timeline. We attached current notes from the physiatrist. We found out later that all the claims the physiatrist submitted for seeing Steve daily in the acute rehab for 6 weeks were all approved. We also attached a personal letter. The family and I reached out to everyone we knew for assistance. I reached out to the Department of Insurance in Arizona, then Illinois, where the policy was based. They said since it was a self-funded plan, they could not help. It being a self-funded plan allowed us another opportunity to reach out to the employer to see if they would cover the care. This is the personal letter the wife wrote to the employer. Even though the employer could not, so to say, approve at any time, they can make the decision to pay for his care. So at this time, we were managing his short-term and long-term disability through his employer and started talking about Social Security and disability insurance and Arizona long-term care insurance. All the while we were working on this, Steve's family continues to pay privately for his care.
What do you know about self-funded insurance plans, also known as self-insured plans? Well, they're mostly present in large corporations, and according to one study, 67% of employed insured workers had self-funded plans. More than you thought, right? So in these plans, the employer takes on the responsibility for collecting premiums and paying medical claims. The employers can contract for insurance services such as enrollment, claims processing, and provider networks with a third-party administrator, or they can be self-administered. So it can look like, say, a Blue Cross Blue Shield, a Cigna, an Aetna, whomever, is your insurer, but really they're only the administrator. Self-funded plans are exempt from state insurance regulations, so you don't have the backing or the assistance from state insurance departments if you have or your client has problems with their insurance coverage. So what this means is Steve's company could decide to approve any and all of his care on their own at any time. The company makes the rules. This can present as an opportunity for the family to plead their case to the employer for coverage at the neuro rehab. So that amount of money, it was really a significant amount of money for the family, but of course it was a relatively small amount for such a large corporation. So what was Melissa's role here? She got on numerous calls with the insurance company and employer, took notes, made sure everyone's tasks were completed. She created a medical timeline that was given to both companies and assisted the wife as she was writing her story about Steve's accident, all in an effort to get his medical care paid for. Now, in this case, the family did get attorneys involved for several reasons. Steve experienced a severe life-altering injury which caused significant financial consequences for the family. Also, when someone feels they have a moral claim and the other party hasn't lived up to their duties or responsibilities, that can fuel a desire to get attorneys involved. In this case, the family used an attorney to represent their interests on several fronts. With the health insurance company, as care was not covered at the SNF or acute inpatient rehab, to represent their interests with the corporations that were involved, as one, it was a work function. The company had a self-funded insurance plan, and Steve had just left a business prior to being hit. Also to represent them with the driver's automobile insurance company. So what is the advocate's responsibility when your client wants to get an attorney involved? A lot of the same as they always are. One, you're going to refrain from legal or medical advice or opinions. You're going to maintain accurate and up-to-date records and documentation. Remember, your notes and records could be required for litigation or simply to assist the attorney in understanding the case. You also should adhere to Patient Advocate Certification Board ethics guidelines, which include honesty, transparency, and confidentiality. Now, I know that PACB has updated their ethics guidelines. I haven't read them yet, but I'm assuming that they didn't just do away with honesty, transparency, and confidentiality. So just remember that you don't own the medical records. Your client does, the patient does. And if they are requested, you should refer them to the medical provider or the organization, healthcare facility that created them. They are the ones that have the ability to release them. Of course, making sure that your client, the patient, is aware. But it is about honesty with your clients. You should always keep the family aware of any requests for your documentation and get their permission to share any of your notes, anything that you have with anyone prior to sharing them. So the last but not least, you really want to stick to that scope of practice and your client contract. So you should have a client contract, client agreement, whatever you call it, that the client signs prior to the beginning of advocacy services. And in it, you should list your scope of practice, the things you do, the things that you don't do, how the client relationship is terminated, medical records retention, all of those things should be in your client agreement. And you can refer back to that. So and look and see what you state is within that scope of practice, what is outside of it. So that does give you a little bit of protection, a little bit of feeling of security that you are staying within that stated scope of practice. Let's take a look at what it was like for Steve and his family at home. First, they had to complete some home modifications, even prior to Steve's return home, with the assistance and guidance of physical and occupational therapists at acute rehab. The wife needed to get a new car so that she could transport Steve. They needed to place a ramp out front, modify the master bathroom to accommodate both Steve and his wife in the shower, along with putting tile throughout the floor in the home for easy transfers and movement. So at this point, the wife wanted to be the sole caregiver. She attended all of his appointments. She knew every detail of his care and all of his medications. She provided all the care for Steve, including assisting with eating, bathing, transfers, and more. She really researched everything about his care. She had him on a ketogenic diet with various supplements, including omega-3 and collagen. She made sure that Steve was included in family outings, gatherings with friends as well. So she was also very active on social media, doing daily posts about his recovery. She reached out to others on social media who had experienced the effects of traumatic brain injuries as well. So she would gather information when she found something new and promising. She would reach out to Melissa and Steve's medical providers, asking if this was something that she should consider for his care. So the providers were very open to explore, what may be considered alternative therapies. For example, Steve received acupuncture and was under the care of a board-certified chiropractic neurologist. So those were some of the alternative modalities that they used for his recovery. But there are others, including LED light therapy, craniosacral therapy, hyperbaric oxygen therapy, neurofeedback, portable neuromodulation stimulation, and much, much more. You can explore some of these at the BART Foundation, and BART stands for Brain Alternative Rehabilitation Therapies. So with the good also came some questionable therapies. Looking back at her notes, Melissa remembered that the wife had heard about this amazing physician who works with patients with traumatic brain injuries. So the wife, Steve, his father-in-law, and Melissa all met with this physician. And Melissa said from the moment she met him, she questioned his abilities and his motives. The program cost approximately $20,000 just to start it. And some of the other red flags that were there was that there was no intake paperwork. He didn't want any of Steve's previous medical records. He asked about if attorneys were involved, and if they had received any settlements yet. So they asked to speak with previous patients or see testimonials on the treatment, and they just weren't given anything. Also, when they went there were just no patients there during normal business hours. No one was checking in, no one was waiting to be seen. It just didn't feel right. So the wife wanted to do everything for her husband's care. That's completely understandable. And yet, she made this decision that it wasn't the best use of their money or time. She was a little bit skeptical of the situation. It was kind of a too good to be true kind of feeling. So some feedback along here is just to remember to hold space for your clients, allow them that time to make that decision themselves, providing them, information and any of your research that you can, but it is their decision to make. So directed by the attorneys, they also met with a team of certified life care planners that included a neurologist and a nurse. So life care planning is a comprehensive assessment by experts to predict care needs for an individual based on medical records, physical exam, research, and data analysis to create a plan to address those needs, which include ongoing financial support. So the life care planning assessment was requested by the attorney for the automobile insurance. Life care planning can be useful in litigation and future financial planning. So Melissa had a clinical background in home care and home health, which I think really helped her to look at the details of Steve's transition home. She also learned a lot working with the therapists at acute rehab and from the life care planners. They looked at the needs of Steve and his wife, and they were able to fill in the gaps that they couldn't with, his family and friends with home care workers. So that included training the home care workers, making sure they fit into Steve and his family's lifestyle. So not always an easy task, but Melissa really does try to be the, facilitator, collaborator amongst everyone who's caring for her clients. So getting the home and the family and friends ready to support Steve and his needs was really a monumental task, with the majority of the work done by his wife, supported by Melissa and his large network of family and friends.
Caring for someone at home is a lot. Being the sole caregiver is a lot. At this point, I had established a relationship with not only the wife and parents, but also the children, the siblings of Steve, and their friends. They all knew me as Steve's patient advocate. I would like to share a letter I wrote. This is a little over 7 months after the accident. I planned and orchestrated a meeting where family and close friends were invited. The goal of this meeting was to update everyone at once on where we were with Steve's care, why we were doing what we were doing, along with help guide them on how to interact with Steve and be helpful when they visit him. When Steve was going home, I kept thinking that Kim is going to need more help. I knew she didn't know what it was like to be a 24-hour caregiver, how draining it is physically, mentally, and emotionally. I knew what her days were going to look like, and I kept thinking to myself, how is she going to do this? I was just getting to know Kim, yet what I did know of her was with every step of Steve's care, she went full force. I mean full force. At times, I got tired just knowing all the behind-the-scenes stuff she was taking care of for her family to survive. Fundraisers, along with fighting insurance, driving every day to see him, getting involved in his care, managing all of his care, knowing everything that was going on with him, medications, treatment plans. Not that I ever told her this, but I was getting ready for her to break. I knew from my years of experience that there was going to be a time when she was no longer going to be able to go full force without breaking down. It just so happened I saw the signs and I reached out to her on Monday morning last week. I texted her if she wanted to get together to talk about Steve's care, reassess where he is at, goals, and the plan, and I thought it might help to talk through everything. And then the phone rang. She broke. I listened. I knew what I had to do, and that was 1, gather more information from the doctor, 2, have Kim meet with Stacy, 3, meet with all of you. So this is like sort of talking about the elephant in the room and what it is Kim needs help with, which means she needs to be vulnerable with us to share her feelings about what has happened. So that day, Kim went and saw Stacy. She is an amazing therapist and human being. We wanted to include her in this meeting, really to help us all, because I know all of you are going through something. So some of the items that we covered during this meeting with the family and friends were nutrition, the use of a modified keto diet and brain recovery, Steve needing to be taken to the bathroom every 2 to 3 hours, the need for briefs in between, the use of a catheter at night, his bathing and hygiene needs, his need for routine and sleep, how to assist in dressing and applying his braces, stretching exercise, the use of a stim unit, iPad activities for speech, his vision therapy exercises, along with trying not to overstimulate him. Can you even imagine all that went into this care for Steve? We also shared how Steve was never going to be the same, and the goal was to get him to be the best he can be. Not a very easy thing to share.
Now, this was a fairly intense advocacy case, especially in the beginning. So as good advocates, I think it's important to do some sort of evaluation of the case, be it formal or informal. So here are some ideas that I have about how to assess your cases. First, you can go back to the scope of practice, your client agreement, client contract, whatever it is, and kind of ask yourself, did you practice to the fullest extent of your scope of practice? Or maybe did you go outside of those boundaries? You can also look at the initial goals or client plan. So Melissa will create this comprehensive client plan for her clients after the initial consultation with a list of client and advocate goals and tasks that are needed to complete those goals. So she can refer to this after the case to see where she started in the case and were those goals met, and then maybe address if they weren't met, what were the barriers, what were the obstacles to getting those met, just why didn't those happen. And maybe it's because circumstances changed, maybe it's because something the client did, maybe it's something she did, but look back at that initial client plan. You can also discuss the case with a client and the family at the appropriate time. Maybe some time needs to pass, maybe it's right away, but you can ask them what they wanted done differently, what could have been done better. Ask them what they thought went well in the case, what did they really appreciate. Those are other ways to kind of informally look back at a case and evaluate it. You could also send a formal evaluation. That might feel kind of like the surveys that you get from the hospital or, medical providers after you've seen a doctor. But it might be useful to you. It might be really appreciated by the client, depending on how you craft this evaluation. It could be when you ask them for a review for social media. That actually could provide some information for you. I think sometimes you'd be surprised at the client's perspective on the case and what they felt, went well or didn't go well. So in an effort to be, more objective with an evaluation, you could also create a list of outcomes that are important to you as a patient advocate and to your clients. These could be things like their health status, their financial status, maybe it could be emotional, maybe it's the type of care that they wanted to receive at the beginning of the case. Maybe it's their living situation, getting into certain medical providers, or whatever the outcome is that's meaningful to you and your clients. You can assess whether those things have changed or improved at all for your client. So also look at the termination of the case. How did it end? Why did it end? I asked Melissa about that, and she said that there was really a natural progression and that Steve's situation had settled, and that they did not need advocacy services any longer. So now, mind you, Melissa developed and still has a strong relationship with the family and wife and father-in-law. She frequently texts and provides support to them. Even currently, she gets updates from them about their situation. She's really developed a, nice bond with the family. So that's it for the case. I hope you have learned something. I hope you have enjoyed it. I do have 3 pages of references, which I will show here. So here are some resources that might be useful when working with clients who have traumatic brain injuries. There are many different types of organizations for all of the various types of therapies involved in treatment. YouTube and social media can provide some information for the families and can be a real source of support for them. As I think we said in the presentation, this wife went to social media, used YouTube, because there are videos of families who are going through the exact same thing that they are. So there are also lots of books available. However, most of these books are focused on symptoms and also on people who have had mild to moderate traumatic brain injuries. There's more of a focus on their cognitive abilities and doing, games, word games, reading, etc., that can help improve that type of function. So again, thank you so much for listening today. We really hope you enjoyed it. And here is our contact information. Melissa and I would be happy to talk with any of you at any time. So please feel free to reach out to us. Thank you so much.